Hello. Welcome to the Center for Health Design's Evidence-Based Design Journal Club. Thank you for joining us. My name is Michael Compton, and I am one of your co-hosts for today's session. As a bit of an introduction, I'm a healthcare designer with Gresham Smith & Partners, working out of our Jacksonville office, although our firm is based in Nashville, Tennessee. For many years, my research and design focus has been on phenomenology in healing environments, which parallels in many ways Dr. Lorenz's work on hospital room design and health outcomes of the aging adult. The purpose of Evidence-Based Design, or EBD Journal Club, is to broaden the design community's knowledge, understanding, and application of built environment research. Just as a reminder before we begin that there will be time at the end for questions. When you have a question, please type it in the chat box at the bottom of your screen, where the red arrows are pointing. Continuing education units are available for this webinar from the AIA and from EDAC. To receive credit for your participation, download the form found in the Files window where the blue arrow is pointing. For credit from the AIA, you will need to complete the CEU verification form and quiz found in the Files section. Once complete, please email it to Shannon Reckline, Project Manager at the Center for Health Design. For EDAC, complete the verification form and retain it for your records. You will need to submit the form to Castle Worldwide at the time of your renewal. Please let me introduce Dr. Sheila Bosch, my co-host, who will be leading today's discussion with Dr. Susan Lorenz. Sheila is the Director of Research for Gresham Smith & Partners and a leader in evidence-based design research. She is a regular national speaker and author of both peer-reviewed and non-peer-reviewed articles. Sheila serves as a co-chair for the Center for Health Design's Research Coalition and a trustee for the Academy of Architecture for Health Foundation. Sheila will introduce today's guest author. Sheila?
Thank you, Michael. It is so good to be here with all of you today. I am Sheila Bosch, and I have the privilege of leading our discussion with Dr. Susan Lorenz. And as Michael mentioned, we are hosting this event to really identify the everyday practical applications of research findings from the published literature. And by the way, a thank you to the Health Environment Research and Design Journal for making this article available to everyone who registered. Today's featured article is Hospital Room Design and Health Outcomes of the Aging Adult, a very important topic, especially as we're seeing this gray tsunami hitting. And I would like to go ahead and introduce Dr. Susan Lorenz. Dr. Lorenz is the Vice President of Patient Care Services and the Chief Nursing Officer of Princeton Healthcare System. She is responsible for strategic management of the Department of Nursing, Cardiac and Pulmonology Services, and Patient Relations at the University Medical Center of Princeton in Plainsboro. Susan earned her PhD from Drexel University. And Susan, we are just so delighted to have you on our session today.
Thank you. I'm really delighted to be here. It'll be fun talking through this topic once again and exploring it a little bit further with all of you.
And if you will, please click on share your webcam so we can see you as well.
You can't see me?
I can't.
It's
maybe
on.
Can.
Sheila, we can see Susan, but we cannot see you.
Oh, that's very, very interesting. Okay, hang on. Now, my bad. Okay. Thank you, Susan, for your patience here.
No problem.
Well, let's go ahead. Today's discussion, we're gonna really talk, and I want to encourage the audience, the participants, to actually type in questions as you go. We may not be able to hit all of them, but feel free to type your questions in the chat box, and we'll get to as many as we can. So, Susan, when you applied and interviewed for the CNO position that you're in now, did you ever imagine you would become a building researcher?
Well, that wasn't my plan. I actually was really looking forward to being a chief nursing officer for a larger healthcare system. And at the time when I interviewed for the position, they, told me, well, we're going to build a new hospital. And that sounded like a lot of fun and something that ordinarily you may not get to do. It's not in everybody's career path. But I had really no idea until I entered into that what that would mean to me in my career and to what it would actually mean to healthcare as we go forward as well. So I guess I would like to start sort of at the end. And I don't know who's forwarding the slides. I'm not able to.
I can do that.
Can you do that? There we go. So I'll start. Thank you. So this is my favorite picture of our new hospital, which opened in May of 2012. So I'm sort of starting at the not the end of the story, but the close to it, I guess. So this is our new hospital, opened in May 2012, and this is way back in 2006 when I first took this position and started talking about our new hospital. I also was in school and pursuing my doctorate degree, and I needed to come up with a research question. So being as efficient as I try to be, I wanted to do something that I could utilize for my work as well as complete requirements to get my doctorate degree.
That's
and well, sometimes. So I spent a lot of time patients thinking about what I wanted to do. I knew globally I thought patient safety was where I really wanted to focus. I hadn't thought about focusing on patient safety as it pertains to design, but given the fact that we were building this new hospital and we were just starting into the schematic design phase, I started thinking about it in those perspectives. Because a lot of times, during schematic design, you'll go into meetings and you'll sit with architects and designers and other folks, consultants that come in, and they talk to you about the evidence-based design and the things that have been proven to improve patient outcomes, improve healing, and improve efficiency of care. And when you're got that research bend, you start thinking, I wonder if that's really true, or where is the research that really supports that? So one of the questions that was in my mind all along was, we had already determined to go with the single patient room. Back in 2006, I believe was the first year that the AIA guidelines actually recommended that, and then it was picked up by most organizations as for all new construction, and we must do the single patient room. So it was early days, and I thought about the patients that we took care of, and I was actually out making rounds one day, and I walked into one of the patients' rooms, and it was two older women, and I asked them how they were doing, and one of the women in the bed said, oh, well, we're okay, but Beth is a little confused, and at night she tries to crawl out of bed, and I look out for her and I call for the nurse when she starts crawling out of bed, or I tell her to sit back down, or helped her to not fall. And I thought to myself, gosh, these two women are in here, they're socializing, which is good for them, they're watching out for each other, which is good for them. So what happens in a hospital where there are no semi-private rooms, where people like this would be alone, where Beth would be alone to climb out of bed and fall on the floor without anyone there to see it. So as I was thinking, I thought, well, I'm going to look at the research around the single patient rooms, because there was a lot of discussion about how they prevent falls, they prevent infection, they promote privacy, promote communication. and promote caregiver efficiency. They also cost, 15% more to build in a new hospital. And I thought, I really wanted to see if, in fact, these things were all true. So as I began my review of the literature, I began to see a pattern emerge, of which was a lot of anecdotal information, very few conclusive studies, which is pretty typical in an emerging field, as evidence-based design still is, but was much more back then, 7 years ago. And I started thinking maybe it would be worthwhile to be able to look back and see really what happens in the patient room from a patient perspective when they're there alone. Are there more falls? Are there less infections? I mean, those are the two big answers, because when you look at the infection literature, as we all know, most infections occur through contact. And contact has a lot of other variables to it besides a single patient room. Excuse me. And the falling, there is that, do the patients fall more often when they're alone? So all of those things was what I took into consideration, was kind of the beginning of my journey, if you will, into how does the design of the patient room actually impact patient outcomes.
Thank you, Susan. It is a really important topic. Also, of course, as value-based purchasing programs are coming online, and your numbers for little acquired infections or falls and those sorts of things, I think it probably has an even bigger impact today than when you did it. You were just ahead of your time, I think, Susan.
Well, I like to think so, but actually when you see some of the findings, those of you who are, actively working in healthcare now, and go, gosh, since 2000, because they really have.
Now, who was on your research team, and how did you assemble it? You were working on your doctorate at the
Working on my doctorate, so I had a supervising professor and I had a committee, typical, academic program. So I had a couple of general doctorally prepared nurses. I did have an architect from the School of Design on my committee, and I did have Jan Stickler, who is the co-editor of HERD, who was a nurse with expertise in interior design.
All right. Well, let's go ahead and go to the next slide. Give us a little bit of background context and some of the key concepts that you explored in this study.
I'd be happy to. So one of the things that is particularly interesting to me is for the elderly in our country, because we are rapidly becoming a country of older adults, and becoming a country of older adults that have a lot more expectations in our management of ourselves than ever before, with a longer lifespan. So we all know that that's not news. So the U.S. population is aging, resulting in increased incidence of acute conditions that need hospitalization. So we're seeing a lot more patients, and the larger bulk of the patients, 50% of the patients we see in our hospital are over the age of 65 in 2006, and I believe we're up to about 70% of those patients now. It's a large number of patients, and the largest of them are in that middle age, that what we call the older adult, or the 75 to 85, and the more frail with the more chronic conditions. It's really important to understand how hospitals should be designed to meet the needs of this population.
Now, looking back, do you think those were still the right questions to ask, or good questions to ask, or would you change that at all?
I think looking back, I might, or even looking forward actually, I think the questions I asked at the time seemed pertinent at the time. For looking at design, what we were looking for is what impacted the outcome of care. So it's nice to have, you know, healing environment and say how really nice the room is and people are calm and comfortable. But what really impacts their care? Are they really safer in those rooms? Are they really getting more efficient care? Do they really heal faster? So kind of look at those things. And there were very few studies out there that really looked at outcomes like that. You know, back in the 1980s when the View of Nature study was done by Dr. Ulrich, that was a very, very empirical study that really had great outcomes associated with that really showed pretty conclusively that the Views of Nature did support better outcomes on patients. So that was the kind of thing I was really looking to do. I think now that we have the opportunity to look at some of these newer or better designed systems, we can start looking to see if what we thought was working really, and that so in that way some of the questions would be different.
Well, let's look at a little bit. Sorry, let me go on to the this we've already. I think you've already covered a little bit of this about sort of the benefits of private versus semi-private. Is there anything else you'd like to add to what you've already said about that?
I guess the one other thing that I didn't mention is the increasing family engagement with care, because I think that's one of those key things that we haven't been able to wrap our arms around, whether the private room exists in a way that it really does increase the family engagement with the patient care and how that actually impacts on the patient. So I think as we go through a little bit more about families, there was a study done early on prior to me doing this study where there was a newer hospital or a renovation, I can't remember which it was, but they went from semi-privates to private rooms, and their fall rate decreased dramatically, and families being able to engage patients, but there was really no evidence to support that, other than it was a few that they had introduced, and the fall rate had gone down. I'm sure there are many variables that affect falls, and there's many pieces of the puzzle that affect whether a patient falls. But I thought that was an interesting one, too, because it would be really hard to study. I'm sure some people prefer to have their family with them, some don't. You know, there's a lot of interesting concepts there.
So I think you've already covered the objective, the purpose of the study is looking at the falls and infection rates in the semi-private versus private rooms for older adults. So you did look at the older population.
Right.
Now, tell us a little bit about the methods that you use, your research methods.
Okay. So I design using secondary data. So what I did was I had two comparison groups, a group of private room patients and a group of semi-private room patients. So private room being the single room, semi-private being a two-bedroom. So there were no larger rooms than that. And I abstracted the data randomly from those patient records for the period between January to May 2006. So what happened was our medical records department pulled the charts for me, and every third chart they pulled and gave it to me. And then they de-identified the data, so I had no way of knowing who the patients were. It was an IRB-approved study, and then I abstracted the data and went from there. So I was looking for, again, the infections and the falls. of the patients and comparing them to the type of room. So this happened in the medical surgical units at the University Medical Center of Princeton. So I didn't use the ICU or places like that where we had very critically ill patients. Of course, child health, because we didn't have anybody over the age of 65 in those areas. So we were pretty confined. Princeton, University Medical Center of Princeton at the time was a 308-bed acute care community teaching hospital, pretty similar in size at the moment. 50% of patient population over the age of 65, as I alluded to earlier, that continues to grow. And specialties include cardiology, general medicine, surgery, orthopedics, maternal and child health. And we have a very similar focus today. So right here is just a comparison of our two types of rooms. And I will tell you that the hospital this was the old hospital. The private rooms were very differently designed. Every single one of them was somewhat different. And they were tucked away into the four corners of the large nursing units. So they weren't close to nursing stations. They were kind of off by themselves. Some of them were large, and the distance to the bathroom was far. Others of them were smaller, and the distance wasn't so far, but the rooms were more cluttered, likely to have more things in the way. And then the semi-private rooms were your typical semi-private rooms that you see in most older hospitals.
Now, getting back a little bit on the methods side, how did you determine your sample size?
The sample using a corrected chi-square, which was a statistical test that allowed us to determine how large the sample size should be based on the observed frequencies of falls in the over 65 population. So what we were looking to do was outcome study with a level of 0.05. And when we did all those calculations, we discovered that we needed 150 patient records. And we added an additional 10% due to possibility of missing data in a retrospective study.
Now, let's talk a little bit about did you include, and what was the basis of excluding some of those patients?
What we were trying to do was have groups that didn't have a lot of variability. And so and looked at the patients that really had very high risks of falls, or that we weren't able to, there would be hard to control because they could have lots of other issues that would contribute to their falling, lots of other issues that contribute to their length of stay, those types of things. So we looked at those patients, and they were patients with a clinical history of dementia, patients who had been bedridden prior to admission, patients who were admitted directly from a nursing home, patients who already had an infection and were in isolation. So if they were an MRSA patient, for instance, they would not have been included. Patients who were incontinent, and patients who had been readmitted in the last 30 days, believing that those patients would be more sick and have more comorbidities than the average patient population would. We also kept the length of stay between 3 and 10 days, which now when I look at that, I think, boy, that was long, because staying in the hospital 10 days anymore, it's an outlier. But back then, it wasn't quite so much.
Tell us, how did you collect the data? You mentioned the records were given to you de-identified, right? What else can you tell us about how you collected the data?
Well, the data was collected, like, as I said, through chart review. So we abstracted the chart, and there were two types of charts at the time, in that we had partial documentation in the clinical documentation system, which was computerized, and partial written documentation. So you can imagine at the end of the day, there's some limitations to that approach, because it's reading doctors' handwriting and really trying to figure out what we were doing in some ways. And there was missing stuff, as I believe that happens frequently. So I looked for gender, I looked for age, and I looked for their fall risk on admission. We looked and captured that data, which we used the Schmid Fall Risk Assessment Tool, which at the time was probably it was actually an older tool even at the time, but that's what we were currently using, so that's what I kept with at that point. It worked for this study. The independent variables, of course, were the private versus the semi-private room. So once we got the patient, that's how they were categorized. So when medical records pulled them, they pulled them off their face sheet based on whether they were in a private or semi-private room. What I didn't know at the time was whether or not some patients who were in a semi-private room might have been in there alone. There was no way to really go back and tell that easily. The dependent variables were nursing and physician progress notes, or where we got those were from the nursing and physician progress notes. The incidence of falls and the incidence of hospital-acquired infections, which we verified by laboratory and diagnostic data. The nursing notes were pretty complete because they were computerized templates, whereas the physician documentation was really much harder to pull together.
Okay, thank you. Well, let's look at your findings here a little bit. Go ahead and give us the general overview of your findings, and then we'll look at each one of them a little more specifically.
Okay. So the average age of our patient population, the 166 patients that we reviewed, was 80.08 years. They were 61.4% female. Their average length of stay was 5.88 days, which again, in today's world, that seems very long. And the fall risk was identified for 69% of the sample, so 69% of them came in with some risk for falling. So in the patients that were in the rooms, we had 5 total falls in the entire study sample. 4 of those occurred in private rooms and 1 in a semi-private room. So there was no statistically significant difference between the type of room and the likelihood of falling, but when we looked at the odds ratio, the relative risk of falling in a private room was 4 times higher. And in the infections, 9 cases of the hospital-acquired infections, 4 of them were in private rooms and 5 in semi-private rooms. There was no significant difference between the type of room and the occurrence of the hospital-acquired infection, which is what we expected. And the patients who developed hospital-acquired infections had significantly longer length of stay than patients without hospital-acquired infections, which also makes sense.
Susan, tell us a little bit more. You know, the number of falls in your sample was small, only 5, and that makes it difficult to really conduct a robust analysis. So, in retrospect, is there anything you would do differently with data collection, given that low incidence of falls and also the healthcare-associated infections?
I absolutely would do that. Would have done it differently, and didn't figure that out till the end when I was done collecting all this data. But instead of collecting the charts by room type, I think I would have gone back and pulled all the patients in that period of time who fell, and the patients who had hospital-acquired infections, and then determined what their room type would be. And I think it would have been much more of a robust analysis had I done it that way. And I keep saying I'm going to do that again, but haven't gotten there yet.
We'll look for it to be published shortly. So what are some of the challenges You mentioned some of the challenges in collecting the data, like you didn't know if they were in a semi-private room. They might have been in there all by themselves. Were there any other challenges that you experienced? I know that different organizations maybe measure falls differently and those sorts of things.
Well, there were quite a few of those types of challenges. In 2006, which was a while ago now, although falls have always been important and always been something that we look to prevent, I believe over the years we've put in more robust fall programs. We've been tracking the data better. There is more national benchmark data out there. There's more standardized definitions for what comprises a fall, because I would be willing to bet you that there was underreporting of falls in that sample, because patients at that time, sometimes patients, if they fell but weren't hurt, it wasn't written down as an incident. There were all kinds of things that you find out when you start digging into it that contributes to whether or not reporting is being done. Today, it's a very different thing. With NDNQI and some of the other national databases that have standardized fall definitions, organizations are much more closely aligned to be able to compare to each other what their rates are. There's been a lot more research in the area of falls in all areas of it, and not just the environmental component, but also the behavioral components, the educational components, the assessments. For instance, today, we at Princeton, we now use the Johns Hopkins Fall Assessment Tool. It's a much more sensitive tool. Probably it picks up patients that our previous tools did not pick up. And as we move forward, we can identify levels of care. We do a lot more interactive education. We use technology a lot more than we did. So all of those things contribute to not having a real accurate picture of what was happening back in 2006. Whereas if you did the same study today, you would probably I would feel more confident in the data and the actual analysis. That was one of the challenges.
I was just curious, within your own organization, do folks uniformly report the data?
We do.
Then or now?
We do now. We did not then. We reported the data internally in 2006. There was no requirement at that time for us to report the data externally. So we now are a part of the National Data Bank for Nursing Quality Indicators, which has many hospitals across the country, which we can benchmark our fall rate per nursing care unit to see where we compare.
Let's look at some of the conclusions your team came to as a result of this research.
So what we talked about was that private rooms could increase the risk of falling among hospitalized older adults. Certainly not conclusive evidence, but depending on the patient, it could potentially do that. Private rooms do not necessarily affect the incidence of hospital-acquired infections, and that, as we've said before, is largely due to the fact that those infections are created by contact. There has been, since that, studies which are really looking at that rooms that are private rooms or that are terminally cleaned are cleaned better than semi-private rooms when they need to be terminally cleaned, which makes sense. There's some more research that's really looking at. So we have some room to go on there. We thought that while looking at it, it was like, does this one size fit-all approach really work for patients, and maybe that's something we really ought to take into consideration. So while we're making room assignments for our older patients, staff are taking into account their age, their fall risk, their disease process, their required therapies, their family, whether their family's involved, not involved, and how involved they are, and their personal preferences about roommates. Now, we don't have any semi-private rooms, so it caused us, once we moved, to say, well, if we really believe that patients they want to be able to socialize more readily with other patients, and they need to be, how do we accomplish that? So we've done some work on, we do have a unit that is specific for elders slightly from our regular med-surg unit to allow for dining, activities and those things for patients that are well enough to be able to get out of, to be out of bed and to get them back to their previous level of functioning. So that's kind of what we're working with right now in terms of how do we keep these patients active and socialized who would like to be part of a group rather than sitting alone in their room.
Total aside, I was in a terrible car accident this summer, and I always had fear in a semi-private room. I would go insane, and actually I hardly even noticed that the lady was there, because I was on painkillers for those few days that I was in there. It didn't seem to really bother me at all, actually.
I think it really just depends. It really does. It's a hard discussion because I feel the same way. I've been hospitalized before, and I didn't want anybody to be in my room with me. It's just one of those, sometimes it's preference, sometimes it's right. I'm sick enough, I don't care. And as long as they're not being disruptive, because there sometimes is some of that goes on, it's generally okay.
There's been some talk about other patient populations too, not the elderly, for whom a semi-private room might be the better approach. I think I've heard organ transplant patients. We're actually right now dealing with the fact that we'd like to include some semi-privates in a rehabilitation hospital, thinking that actually may be beneficial for those patients. Are you familiar with what patient population semi-privates?
Yes, I think, I've delved into this a little bit. We recently became a Joint Commission Center of Excellence for Joint Replacement here at the hospital. The big pushes is getting those patients to develop relationships and to have group therapy. That's what we offer here. But in fact, what we're trying to do is provide them with that level of support from each other, that, that theory that a group can support the individuals within it better when they understand each other's issues than if you're just an individual going at it alone. And I think that's true. We've seen that as a model in behavioral health, which is why hospitals really go to private rooms. In fact, when we built our eating disorder unit here, which is largely adolescents, and adolescents, as you may know, like to travel in herds. So if they're not together, they're on their phones or whatever they're doing. So they like to be together all the time. And when we did build this eating disorder unit, because we wanted more therapy space, we actually were semi-private rooms in that area. Not all, but some. And we then had to change our licensing because of the recommendations. about the private room to a behavioral health license from a medical surgical license in order to be able to do that.
Okay.
So there are those populations out there.
There's a question that has come in, and I actually have part of an answer, I think, to this question too. He says, it would be interesting to know the link, if any, between a patient having visitors and the fall and healthcare-associated infection rate. Now, we did a study at Tampa General Hospital. We didn't look at falls and infections, unfortunately. We just thought a family-centered design actually increases family presence. So it would be really interesting to, if we had taken that a step further and said, are there differences in the fall or infection rates? But do you have any sense for the family presence had on falls or infections?
I don't. I will tell you that our fall rate has dropped since we came. We did see a, but it's been here 18 months, so I think we've had a fair amount of experience with the building now. That initially when we moved in, our fall rate spiked. So in July of last year, we got a little concerned and said, what's going on here? I think it was as we were all adjusting to the size and all of the space and the that we didn't have in the old hospital and how it worked. Once the nursing staff really got adjusted to how all that worked, the fall rate has started to decline and continue to decline. Whether or not that has anything to do with visitors, I don't know. It would be interesting to study it. I have a bias that that visitors don't really patients, and I'm sure other people have had patients too, where they feel more confident to walk because their mother, sister, father, brother, or whoever is there with them, but they aren't trained to help them, or to assess. Because if you recall, or if you're aware, things like syncope and those types of things are considered falls because it's expected that the nurse assesses the patient for those risks before they get up. So a visitor is not going to impact that necessarily. Be able to call. Sometimes they don't call for help till it's too late because they don't realize the patient may not be able to ambulate.
That's a very good point, actually. So let's just talk about some of the design implications. So you basically went into this trying to look at a design to inform your decisions about whether or not to include some semi-private rooms in your new facility. And so what are the implications maybe more broadly to others and architects and designers?
Well, we actually really were not able to inform the design of our current hospital because by the time I even started this study, we already were down the road of the single patient room. What it did for us was, it created a lot more questions than it did answers. So it informed our next research project was we actually we wanted to see of our single patient room was going to impact our outcomes of it. We looked at falls, we looked at hospital-acquired infections, we looked at medication errors, we looked at pain management for these patients. We looked at a variety. We looked at staff efficiency, we did surveys, we did all kinds of things, and we did it over a 3-year period to see what modifications we might want to make in the room to make it safer, a more healing environment, and obviously more efficient for the nursing staff. So this study on the design, on the semi-private versus the private room kind of helped us think, say, okay, what are the real questions here now? And since we really don't have the choice of building semi-private rooms in our hospital, how are we going to make sure that these single rooms that we're designing are going to meet the outcome? And so that's where we moved from.
That's a very, very good point. And I think that's so true of a lot of the evidence-based design research is that we do often end up with more questions than answers. And I think, we need to be able to replicate studies more so that we are able to look at these patterns of findings and come to some strong recommendations for the community in terms of best practices. It's certainly a struggle, but the thing is, the beauty is that studies like this one can go on to inform these bigger and more in-depth studies. I'm just curious, what are some of the things now, looking back and after having done your additional research, that you might, just tips you could give to architects and interior designers on things you might recommend they always do or never do, or do you have anything, got sort of, snippets like that here?
I think that I will tell you, out of all of the design modifications that we made, and we're in a brand new building, so everything's different here. There isn't any department that looks the same as the old one did. But because we actually did the research on the room, we built it out, we did simulations in it, we worked in it, we took care of patients in it, we got their feedback, and we compared it to our old private room. We made, hundreds of modifications of details, things that were important to the nursing staff as they took care of patients, things that were important to the patients, and simplest things such as where handrails should go. Where does the toilet paper roll go? I mean, I can't even tell you how many hours we spent discussing that. And because it's important to the patients and we have had little to no complaints about the patient room, nor have we had any real issues with care provided there. In comparison, our emergency department, which was totally designed differently for a whole different model of care, even though we trained everybody and we worked and we had everything set the way we thought it was going to be, we didn't get to practice in it. And we came here on the first day, and we instantly were mobbed with patients, which is great. But we didn't have any opportunity to grow into our space. And the staff, it was very fascinating to watch it. They all reverted back to what they knew, which was not effective, efficient use of the space. And it took us a year to get to the place, to get to the operational processes in which we designed that space for. So I think that being able to function in a space and really learn from it, I think the model room, a lot of people said to me, I don't know why you're doing that, it costs a lot of money. It'll be just as good if you build it like in a cardboard box somewhere. It'll be fine. And we didn't agree with that because we wanted it to be as perfect as it could be, and I think that it's pretty darn good.
We learned time after time how important those real life mock-ups are, with every little detail worked out to be looked at and changed potentially. Let's look at the other questions that have come in. One of our participants asks, all of the healthcare-associated infections were the same type of infection, or what infections did you include in your sample?
Well, any infection that was determined to have been caused in the hospital. They were largely, if I recall correctly, urinary tract infections, and I think there were a couple C. diffs. I don't think there were any hospital-acquired pneumonias in the group. There might have been one, but we didn't exclude any of them. But what's important around that infection list, and I didn't mention this earlier, but was a limitation to the study, maybe there wasn't any hospital-acquired pneumonia in the group because the length of stay, we excluded them at 10 days. So we would have never known if somebody had gotten a hospital-acquired infection who stayed 11 days or 12 days or 13 days. The same thing with the falls. If somebody fell and fractured their hip or something and it created a longer length of stay, they were automatically excluded from the study. So we might have missed out on some of these patients. So there might have been a broader variety of infections. I mean, typically C. diff and the urinary tract infections or catheter-related infections are the biggies that we see as hospital-acquired, but hospital-acquired pneumonias do occur as well.
I do want to take a minute to encourage our participants to jump in there with some more questions. One of the other questions that has come in is, are you, have you observed any advancements in patient bed design or any other, I would like to expand that, not just to the bed design, but perhaps other within the room kinds of things you can do to reduce falls. But they were specifically asking about like taller bed rails, and I know bed rails actually I believe have been associated with an increase in falls as opposed to a decrease in falls. So do you have any information about that question?
I think it's the technology. It's that smart room, if you will. It's that technology within the room that allows us to be able to impact those outcomes and how we utilize it. So the bed, the bed is part of that, and the advent of the beds that go low to the ground are great in terms of preventing injuries, falls from injuries. I will say that when we purchased beds that went lower to the ground, our patients that fell out of bed had less injuries, although most patients fall on their way to and from the bathroom. So that big environmental design feature of adjacency of the bathroom, that you're not maneuvering your way across a whole room with IV poles and tables in the way and all of that, I think is really important. And the technology, so what we have in our new hospital that we didn't have in our old, we had patient bed alarms that on the new beds that actually went through the call lights, but they, you had to be within the proximity of the call light to hear it. We had personal patient alarms, but they were on the patients and they didn't go through anything to identify anyone. So now what we have is both bed alarms and personal patient alarms that ring through, not only ring to the call light and to the nurse's station, but ring through to the individual caregiver's phone. And that, I believe, once we learned how to work that and got used to that, has really supported our being able to reduce our fall rate. So I think it's all about all those things that are in the room that have to be working in, synergistically together. It's not just about, well, it's a nice room or there's a rail between the bed and the bathroom, or there's there's lighting issues. So we all know that we need to have those low-level lights for depth perception for our patients, and so there's so many variables that impact it.
Yeah, I'd like to just take a minute, too, to plug a paper published by the Center for Health on falls and the hospital environment that Dr. Maggie walk-ins can for free from the would encourage those of you interested in falls to take a look at that work, which is excellent. One of our other participants has asked, why were patients prone to falls excluded in your sample?
You know, it's a difficult question. We went round and round about that. It was really, we really didn't know. My supervising professor and I and my committee really wanted to, remember, this was a doctoral study. So it was a first-time big research project for me. I had never completed part of things, like how to make it as simple as possible, but still get results from it. So we tried to control the variables, and those patients that were really prone to felt if we included all of them in the end up with this fall, we might skew it in the other direction. I think the more pertinent exclusion criteria was that length of stay exclusion. If I had to do it over, I would not have put that in there. Because I really patients that had fallen into the regular patient population, weren't prone for falling, were prone. There were 69% of them, remember, that met fall risk criteria. So it wasn't like they weren't. They just didn't have all those other comorbidities. But that length of stay piece, I think, prevented us from getting higher numbers of problems.
Thank you. Okay, so with every study, of course, there are limitations in funding and time and all kinds of things. What would you say are some of the greater limitations with the study that you did?
Well, again, this study was very single-mindedly focused on one institution for a brief period of time. So, and going about it the way I did, which I alluded to earlier, pulling as a way to categorize the patients, really didn't allow me to get to why patients fell or didn't fall, or why they got infections or didn't get infections. So the robust analysis was difficult to do that. The bad part about that was I think I was on my 150th chart when I figured that out, and I wasn't going backwards at that point. So the inclusion criteria, like length of stay inclusion criteria, limited us as well. And I believe that the falls were underreported. We talked about that a little bit too. Lack of standardization of a definition. I was new to Princeton at the time that I came and did this study, and I purposely took the month April, so I went January through May, so I really had no impact on leadership on these rates because I felt like that was important to be able to get that, and I know that we had some inconsistencies in how we reported and what definition we used for reporting. Mm-hmm. The reliability of the data from the patient records was very difficult to ascertain, particularly the handwritten notes of the physicians, although there were times where things missing from other aspects of the chart that made it really hard to find. So then you're going searching for incident reports and other types of data without identifying the patients to see if you can actually verify that, yes, the patient, it sounds like they fell, maybe they fell, it sounds like they had an infection, maybe they did, maybe they didn't, because I really wanted to validate those. And the other piece that was key was that I really didn't have any good information about the room and unit design. So how did that unit work? How did those rooms work within that unit, and how did that impact on the study? Because I think, if you recall, I said to you that those private rooms, they were in 4 opposite unit, the furthest corner from the centralized nurses station. So they could have been the wellest patients on the unit. I don't know. There's no way of knowing what that patient population really was. We knew their diagnoses, but we didn't know why they were in those rooms. Did they get assigned it arbitrarily because it happened to be the only room open? Did they pay for it? Because at that time we were charging patients for private rooms. Or did they get it because other patients needed to be closer to the nurse station? So we know none of them were in isolation because we excluded that, but it was hard to determine those things.
Well, we're going to just continue to open it up to some additional questions. And, if you haven't gone ahead and typed those in, I encourage you to do so. Let me look here. It looks like a couple of other questions have come in. One asks, were there any trends noted with certain rooms having higher rates of fall or HAI, regardless of the single versus private room? And you said you really had very little information, right, about the physical design of those rooms and how that compared. Is that correct?
Right. I did. And I had, I had little, personal information about the way the units were designed in those rooms, having not been employed there very long and not worked as a nurse on that unit. And there was also, when we were preparing for this, we had thought we could get a drawing of the room in the old hospital, and we don't even have construction documents. So, those things weren't even available to even figure out why things were the way they were.
Yeah, Eileen Malone notes, perhaps those patients that were put in those private rooms, maybe they were hospice patients that needed more, maybe perhaps the quietest part of the unit, but you really don't have any way of knowing.
Well, I do know diagnoses, so I do know how many patients were oncology patients, whether they were hospice or not, I don't know. I would say based on the exclusion criteria, it's unlikely. But the other interesting point of that is that, one of the studies that I read while I was preparing for all of this and really thinking it through was that hospice patients in a hospice were surveyed in an inpatient hospice as to their room preference. Would they rather be alone or with another patient? And the families were also surveyed. So the families all said they wanted their loved one to be in a private room. And the patients all said they wanted to be with someone. They didn't want to be alone. It was an interesting, very small study, would need to be replicated, but interesting anyway.
It's funny, I actually just read that same study a couple of weeks ago.
Did you?
And I thought it was really interesting how the family member perspective was very different from the patient's perspective. Well, we're down to just 3 minutes left for this session. Looks like someone may be typing a question, so we'll give you a minute just to type. And again, I just want to thank everyone for joining us today. These evidence-based design journal clubs, which the center kicked off just this year. This is the 4th for 2013. I'd like to just put in a plug. Keep your eyes open. We actually have decided to do 6 EBD Journal Club sessions in 2014. So I think that you'll can look forward to those coming online. And here is the question. It says, if there were only 4 private rooms on the unit, what was the number of patients out of the 166 in private rooms versus semi-private?
Okay, let's see. I'm trying to find, there were only 4, but remember I pulled a lot of data and there were 4 per unit, so it wasn't just 1 unit. So it was roughly half of each. So to compare, I don't remember the exact number. I'd have to.
That's okay. Roughly half is good.
Right, that was the intent. So it did take a while longer to get the private room patients, through the randomization would have been easier if we had more, but we didn't.
Right. Okay, well, I think that concludes. Thank you so much, both Michael and Susan, for your participation. Again, I want to thank the Center for Health Design for making this forum available for anyone free of charge.
And thank you, Sheila, for facilitating such an interactive, informative conversation. One final reminder that if you'd like to earn continuing education credits for this session, download the form found in the Files window. For credit from the AIA, you need to complete the CEU verification form and quiz and email it to Shannon Reckline. EBD Journal Clubs will continue, as Sheila mentioned, in 2014. Though the articles and topics have yet to be determined, we will continue to offer the Journal Clubs on the first Wednesday of every other month, starting in February. Please check with the CHD website as well as look for email announcements for future sessions. Finally, this event is brought to you by the Center for Health Design's Research Coalition and the EDAC program, Evidence-Based Design and Accreditation Certification. And special thanks to the HERD Journal for providing free access to today's article. If you have not done so already, we recommend subscribing to HERD. Your feedback is important to us. Please take a moment to complete a quick survey, the link at the bottom of the slide. This concludes our event. Thank you again for joining us, and everyone have a great day.
Thank you.